Hello, my name is Maria Walker, and I'm going to talk about midday fogging and intraocular pressure and give an update on what's going on in the research world with both of these phenomena. So midday fogging and increased intraocular pressure are two of the certainly more hot topic types of things that we're talking about with scleral lenses. So there are potential contraindications to lens wear, although I'll say neither of them really would preclude somebody from wearing scleral lenses per se. But let's talk about each of them and kind of where we are with the research and what this means for the entire state of the scleral lens industry. So in terms of midday fogging, most of us are probably familiar with what midday fogging is, but if you look here, you've got a scleral lens on the front surface of the eye there, and then your tear fluid reservoir between the lens and the cornea. They're labeled in this closer up image on the right there. And then if you look at the bottom here, this is showing that same relationship but on OCT and in a patient who has what we call this midday fogging. And the midday fogging is basically just when debris accumulates in that fluid reservoir. So if you hear me say fluid reservoir, I'm talking about this area here, this tears that are between the lens and the cornea. And of course, when I say midday fogging, I'm referring to when we have this debris accumulation in between that lens. So here's just shown another way. You can see it doesn't typically happen immediately when a patient puts a lens on, right? So it classically occurs after about 3 or 4 hours of wear, although I will say it can occur pretty much straight away, but I think for the majority and the most classic presentation, it's going to be after a couple hours of wear. And keep in mind, this is going to happen to some degree in about a quarter to a half of all patients wearing these lenses. So you'll see it accumulate on OCT over several hours. Here's an optic section. This patient has a really thick tear reservoir. We'll talk about why that can help to promote more midday fogging. Here's a video of a patient, and you can see this patient has a lot of debris, and you can see it over the pupil. And this patient even has these really big globular forms. And so when we say midday fogging, at this point, I'll still sort of lump everything in together. But of course, we can probably appreciate that something like this with big debris may have a different etiology and certainly a different composition than somebody like this patient here who has more fine, diffuse, kind of what we call milky debris. And one thing to note here that we'll bring up later is on this patient with the more kind of larger debris, they have some movement of their lens there. So if we look at the fluid reservoir in general, this is an image from Dr. Muriel Shornack, who offered this from a paper that they published here in 2018, looking at the optical density of really just any patient that's wearing a scleral lens. And what you find is regardless of if they experience this quote midday fogging, you are going to get increases in what we call the turbidity or the optical density of that fluid reservoir. So you can see over here a few studies, and I'll kind of pepper in the research where it's been done here. A few studies have looked at this, and they all find the same thing that we're not surprised by, is that the optical density of that fluid increases over several hours of wear, depending on when they measured it. They had a little bit greater or lesser amounts of an increased turbidity. So not every patient who has an increased optical density or turbidity in the fluid reservoir is going to have these symptoms that we refer to as midday fogging. So when we look at all the research that's been done on midday fogging, there's been a few different papers, but we still don't know a whole lot. A lot of what we know is what we call anecdotal, which basically just means that we don't have any real evidence to back up our findings, but it's the things that we sort of see in clinic that many of us notice tend to work. So I think on one hand, we can use those, kind of colloquial recommendations to our advantage and see how they work in our practice. But we have to be careful to not make too much of a formula on how to deal with these patients, because so much of it is individual patient-based and even potentially environment-based. And so we'll try and focus on what's really been shown to help in the research, not just what one doctor found worked for one of their patients one time. So in terms of the research that's actually been done, you know, the first thing to talk about here is tear assessment. So a few studies have actually, you can see the lens can be removed here, and there's actually fluid in the basin of that lens, so you can collect that fluid and test it for different proteins, lipids, cells, really whatever you want you can test for. And it's quite a large volume of tear fluid, certainly compared to what you can capture from the ocular surface itself. So we have some of us researchers taking advantage of the opportunity to use this larger volume for our assessments. So in general, and I'll go through this because I know this slide has kind of a lot going on. In general, looking at the tear composition of the fluid reservoir, there's been 4 kind of major studies that have looked at all at that fluid reservoir. And you'll see these top 2, one published by our group here this year, another published by some folks at University of Alabama in 2019. Those are the 2 studies that have looked at the fluid reservoir and actually compared it in midday fogging, namely this study here, this Postakov study, which is actually looked and compared. We had some subjects with midday fogging, but in that study didn't actually compare them. But they found to have increased leukocytes, which are white blood cells, and specifically increased neutrophils in that tear fluid reservoir in all subjects, and more so in midday fogging. Down here, I've actually just kind of given the highlights. This is the data, and I would encourage any of you to go into these papers and read them yourselves, showing some increases in MMP9. You can see that was found in 2 studies in that fluid reservoir. But remember that a lot of these patients are keratoconus too. So they have high variabilities in some of these mediators. An older study just looked at calcium. But again, highlighted down here is really the clinical relevance that we took from those studies. So you can see in these first 2, in these first 2, we say kind of inflammation or inflammatory tear proteins may be accumulating in this fluid reservoir. But we really don't know what that means. And I'll say that again and again, is all these things you can say there's X, Y, and Z in the tear film, but nobody's tested these for any type of functionality. We don't know that these proteins, when they're found, are even functional. They could just be what we call kind of just like a dump reservoir for stuff that was on the ocular surface maybe overnight, or just is getting pumped in during lens wear. But we really don't know, and we don't think that there's any significant functional aspect of this, because we don't see things like staining and increase in inflammation and hyperemia necessarily in these patients, or we haven't had good studies to really tell us what the ocular surface implications of having A, midday fogging fluid, but B, increased cells or other inflammatory proteins in the tear reservoir. These bottom 2 studies again show we might have some tear stagnation, no effect on tear calcium. Those aren't so much related to midday fogging per se, and really neither is this top study, but those are the limited work that's been done to look at what the actual fluid reservoir composition is.
Miro 1 month delivers one of the highest levels of oxygen transmission. Available in sphere, toric and multifocal. Miro 1 month contact lenses from Menicon.
So part of what was published in the previous study from our group there is some data that we actually have not published. We did an abstract, but Haven't published it yet. And this was just looking at midday fogging and a couple of different, and this specifically was looking at midday fogging. We looked at total protein concentration. You can see here on the left, more protein, greater concentration of proteins in the midday fogging than the not a big surprise there since we see more debris. But again, the functionality of these proteins is unknown. So it could just be it's kind of this reservoir where debris collects, but does that debris have any implications other than, of course, blurring vision, which I don't take lightly, but certainly we'd be really concerned if there was a bunch of, if all that debris was active and causing some physiologic change, which from all that we've tested, we can't really convincingly say that it has. Again, looking at the lipid concentrations here on the right, same thing. You have a greater concentration of lipids in the midday fogging samples. Again, not something that is surprising to us, certainly. We did also look at the MMPs, so MMP 9, 7, and 10. We didn't actually find a difference in MMP 9 in this group, and certainly when we compared midday fogging. MMP 7 and MMP 10 were significantly greater in these midday fogging samples. So again, whether or not it's just because there's just more of everything in these samples, or whether or not that actually has some sort of consequence, I think we need to test more things in these. We know that there's hundreds, if not thousands, of proteins in the tear film, and you know, maybe half as many lipids, or a lot of lipids in there, and metabolites and other things. So lots more to look at here for sure. Just taking a little closer look at Cameron, Dr. Postnikov's study. This was the UAB study I mentioned. Just looking at exactly what they found. Like I had mentioned, they tested leukocytes, which are, of course, white blood cells, in 40 different eyes wearing scleral lenses. About half of them experienced midday fogging in this study, and they found, again, specifically that neutrophils were increased. Now, that, again, may not necessarily mean anything. Neutrophils are the most abundant immune cell. They're certainly the most abundant immune cell in overnight tears. That's another thing that this group had studied, is just overnight tears in general. So we might just be putting a lens on in the morning and trapping the cells that were there overnight, which would be predominantly neutrophils. So hard to say, again, if there's a real physiologic consideration here, but certainly we know that these people have blurry vision. So in any rate, we want to be able to mitigate this. And they did find that you had at a 2.24 odds ratio of experiencing midday fogging if you did have greater apical clearance, which we'll talk a little bit more about. So in summary of what these composition studies have shown, right, we know there's more protein, more lipid, MMP 7, 10, and leukocytes in midday fogging, but again, no functional data on whether or not this has any actual function, or if it does, what the physiologic implications of this are. I think the take home here is we may have some of these increased inflammatory mediators in the fluid reservoir. We don't know if there's any other visual effects other than the visual clouding. And what I'll talk about next, which really ties into this take home, is that we need to start thinking about this, and I think we are, as more of a patient-specific condition than a lens-specific. We jump to this fix-it of how can we make the lens fit better to reduce this. And I think if anything that the studies have shown us, which is a lot of variability, I really think that shows us we need to be looking and focusing more on what is the patient characteristics that cause this to occur, and how can we mitigate those. And I would imagine that a lot of these patients are going to have some increased inflammatory mediators in their tear film naturally. That's sort of what we're starting to see. So let's talk a little bit about the symptoms and the associated factors, specifically those patient characteristics and also lens fitting characteristics that might be associated. So it's a really nice paper that just came out and actually is still technically in press, because I think it's coming out in the December issue of Contact Lens Anterior Eye. This is factors associated with patient-reported midday fogging. So kind of a lot of pertinent negatives here, but some really interesting pertinent negatives, right? So they looked at 248 responses from different practitioners. They had about a 25% or 25% patients experiencing midday fogging. They looked at all different factors, features of the lens fit itself. They did not find differences in diameters, in landing zones, so in the toric, quadrant specific molded lenses. They found no difference in the duration of lens wear, and they didn't find any difference in the solutions used. Now, in terms of the solutions used, most of the patients use saline, so it's not really a study that was set up to compare, but certainly looking at diameters, landing zones, and duration of lens wear, things that we all thought were associated somehow with midday fogging, are not associated in this case. Now, that doesn't mean that there is some connection. It means that we really don't know what that connection is, and we can't find it in this study. So I think really interesting, and we'll see what some of the follow-up studies will come from this. So there's another study that just came out, was looking at the change in symptoms with a different solution, right? So we think, oh, maybe a different solution will help. And there is this new solution, Neutrophil, comes out, right? It's got not just sodium chloride, but other essential nutrients that we know are present in the tear film. So let's get them into this solution. Now, they had about 20 different subjects here, which isn't a huge sample size, but it's some people. Didn't find any change in visual acuity, and actually didn't find any change in midday fogging either. But they did show some improvements in the dry eye symptom score, some of the burning, grittiness. So I think that the solution has its place, but again, not really making an effect on the midday fogging. And so I think, again, bringing that back, I think we're talking about more of a patient-specific condition, not necessarily something that's going to be changed with a lens or a lens fit or a lens coating or a lens solution, right? This is something that we need to address on the patient level. So in terms of fit management, well, the one thing, and I'll summarize again, the one thing that actually has been shown to reduce the occurrence in patients, and I say reduce, not eliminate, is reducing apical clearance and limbal clearance. So we know that we can reduce the thickness, and that makes sense, because even if these patients are going to have midday fogging, we want to make that layer of fog as thin as we possibly can, of course, right? And so reducing clearance works. Don't touch the cornea, but if you've got a patient who has midday fogging, first thing I do, always reduce that clearance as much as possible. Now, this landing zone diameter, right? Do we do a toric or more aligned fit? Do we do a large? Do we do a small diameter? That's where it gets a little bit muddy, right? And we're constantly asking ourselves, what is the best landing zone or haptic zone to reduce midday fogging? So there's a common theory where a tight-fitting lens will cause more midday fogging. And so you ask yourself, where did this actually come from? And this was actually looked at by some of my colleagues at the University of Houston years ago. And they showed that they had 15 subjects, and in those 15 subjects, the patients who had interrupted wear, which was associated with midday fogging, showed a higher percentage that had tight-fitting lens than those that didn't. Now, they didn't say this, nor was it intended to conclude that a tight-fitting lens is causative of midday fogging. They saw what we call a trend of more tight-fitting lenses in that group. But in a pilot study like that, we really can't make any final conclusions about that. That being said, remember back to our video in that one of those first slides, we had a patient who definitely had midday fogging. Their lens was moving. So I know that they probably didn't have a tight-fitting lens edge. So there's something else there. It's not just a tight-fitting lens. It's not just a loose-fitting lens that causes midday fogging. Again, I think it's more patient-specific than it is lens-specific. And the other one, which always cracks me up, is depending on who you're talking to and depending on, which team you're on, large or small diameter lens, they'll tell you one causes midday fogging more than the other. There have been no studies that have shown that a large or small diameter lens has any different predilection on midday fogging. Again, we need to think patient-specific, not lens-specific phenomenon. And so I posture here, maybe we should really be focusing more on treating our patients and not focus so much on changing the fit in these individuals.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
And so what do I mean by that? Well, we know that there's some characteristics and some behaviors that seem to be associated with midday fogging. We know patients who have ocular surface disease, certainly severe ocular surface disease, if they're wearing lenses for this ocular surface disease, they almost all get some amount of midday fogging. So the key to those patients, as best you can, treat that underlying ocular surface disorder. The other thing I'll say is, how many of us are asking our patients what their eyes are like in the morning? Do they have this crustiness here? Because those patients who wake up with crusty eyes in the morning, those are your patients who have more leukocytes, more neutrophils. That's what those are. That's what we think those are anyways, is neutrophils there from the overnight tears. So maybe they've got this, morning sleep, as they'll call it, or eye crusting. Maybe those are patients you need to do a morning lavage or eye wash. Anti-inflammatory medications. Ask patients about itching, rubbing, educate them about how touching their eyes and irritating their eyes is going to make this type of condition worse. So I think we still have a lot to learn here, but certainly the research is showing us that we don't really find any great home run connections between the way a lens fits, other than apical clearance, and the amount of midday fogging. So to summarize here, really kind of unclear the specific causes and effects, but may just be that we've got a dump, basically, of debris in cells with no functional consequences, which is the best case scenario. But of course, we've still got visual consequences that have been well established. So we'll keep on working to figure out how we can manage this better in patients. But, there's many recommendations for management. And although few of them are evidence-based, I still say some of these non-evidence-based recommendations may be helpful depending on your patient. It's worth a try. Most of them cause no harm and could potentially help the patients a lot. A morning eye wash, like I mentioned, and I'm not the first to mention that, has some anecdotal evidence at helping. Oftentimes we'll say avoid removing and reapplying the lenses. That one's a little bit less clear and really quite anecdotal, but it depends on your patient. If you have patients who have trouble and they're removing and reapplying, try it the other way, or vice versa, and see what works for them. Sometimes we can use these more viscous application solutions, or you can use some of the other application solutions if you find that they work for your patients. And sometimes it just helps them feel a little bit better, and that's okay too. And the same with toric spherical peripheries. We really don't have a recommendation because nobody has really proven that one works better than the other in terms of improving midday fogging. And I think certainly we can all, hands down, every time, reduce apical clearance and limbal clearance as much as possible to while not touching the eye, to reduce the thickness of that. And remember our patient-specific risk factors: allergies, ocular surface disease. These things need to be treated, and treated early before patients are in lenses if possible, to really improve all their chances of success with the lenses. Now let's put midday fogging a little bit in the back corner for now. We'll talk about intraocular pressure, which I think is a really exciting and certainly a hot new topic that gets a lot of attention nowadays. So this comes you know, we've been focused on scleral lenses affecting the anterior segment for so long. But what about the fact that this lens lands on the anterior segment, applies pressure to these areas here, and ultimately can apply pressure to the optic nerve head. Now let's take a closer look and remember that our lens is landing right here overlying this anterior chamber. Here's our trabecular meshwork. It's kind of easier to understand with these diagrams up here. We've got conventional outflow of aqueous humor through this trabecular meshwork out into Schlemm's canal and making its way to the episcleral veins. We've also got passive movement out through the sclera and out through the episcleral vein. So this is where the fluid is flowing out of the eyes. So it's very important that this does not have too much outflow pressure, i.e. if a scleral lens is applying pressure to that area, because it will increase the resistance and can, of course, increase intraocular pressure. So this is also not something new. This was back in 1968. It was talked about as scleral lens cling by Carolyn Miller. Okay, and they ultimately estimated that they have about a 5 to 18 millimeter negative pressure force on the anterior segment from the scleral lens. And so, of course, if you're thinking that you get an equal and opposite increase in IOP, that would be dangerous. Now, that doesn't mean that there's an increase in equal and opposite increase in the pressure, but it certainly has the potential to affect intraocular pressure. So we actually did the International Forum for Scleral Lens Research about 6 months or 8 months ago now, 10 months ago now at GSLS in January of 2020. And this was just a summary article, and this is a table we included in that summary article that we just published in September last month. This was just a summary of the currently, or at the time, the current studies on scleral lenses and an increase in IOP. Now, most of these patients, you can see lens IOP was measured when lenses were off. Couple lenses were measured on with the diaton, which is a transpalpebral tonometer. You can measure the pressure with the lenses on the eye. We'll talk about the diaton and how useful that instrument is. But basically, if you look here in the last column, these are the changes that were found. So with this transpalpebral tonometer, the diaton, we saw some increases. We also saw increases with the eye care in one study, but nothing that really strikes you as too extreme. And even some of these studies showed a slight decrease. So a lot of variability. We still don't really know what the story is there at that point. So let's just talk a little bit about where that current research has come this year and kind of where we're at now. So if you look at all the different instruments, we have so many different instruments available to measure intraocular pressure, right? So here's our eye care Goldman tonometer, something called the Schweitz tonometer, which is on a study that was just published. Use that. Tonopen can be used, pneumotonometry, and then, like I mentioned, we've got the diaton transpalpebral tonometer. So like I said, that paper published in September does not include these 3 papers that were published also in September in Optometry and Vision Science in their scleral lens issue. And so one of those is from our group, so I'll go through that one a little bit more thoroughly since that's the one I'm most familiar with. But first, I'll just touch on the other 2 studies that my colleagues have done and what they've shown there. So this first one by Jennifer Voigt, she looked at comparing pneumotonometry, which was one of those that we saw, with transpalpebral tonometry. And she found that there was a change in the intraocular pressure that they measured with the diaton, no change found in their pneumotonometry measurements. So kind of consistent with what other people had seen with when you use that diaton, showed a bit of an increase, but not with the other instrument. Here's just a table. I'd encourage you to go look through this paper on your own if you're interested. Certainly if you're interested in using these techniques in your office, they do a really nice job describing each of them them and how they actually take the measurements. So, but ultimately didn't find much of a difference when they were measuring before and after scleral lens wear. This is another cool paper that was just published too. And this is that Schioitz tonometer, if I'm saying that right. And they did, you can see here that nice image right from their paper shows that they measured over the sclera with this tonometer. And you can see this nice graph here showing really no change at all. And even after the lens was removed, there was no change measured in their scleral IOP measured using that instrument. So again, we're seeing not much change, but keep in mind, every one of these studies uses a different instrument, a different technique, all sorts of different things. And now I'll share with you the study that we did, which again, uses a different technique. So I think we all need to kind of get together and figure out what is our standard protocol for measuring this so that we're all measuring it the same way. I think that will be really helpful going forward to be able to compare some of these studies. So we took a little bit of a different spin. We actually looked at IOP using the eye care and using the diatom, which is that transpalpebral, but we also measured optic nerve head morphology, and I'll show you why in a moment here. Just to mention, we did use little smaller lenses for this particular study.
Hello, everybody. My name is Jason Nichols, and I'm the program chair for the Global Specialty Lens Symposium and our new meeting, the Global Myopia Symposium. We look forward to bringing you cutting-edge information each year. And again, we look forward to hosting you in 2021. Thanks, everybody.
So if you think about how the optic nerve head is affected when the IOP changes, we know that long-term chronic increases in IOP, of course, can cause damage or thinning of the retinal nerve fiber layer at the optic nerve head. And so what I didn't know until a couple of years ago, and what glaucoma experts certainly know, is that if you have a transient increase in IOP pressure, so just a fluctuation that spikes a little bit, there's a bit more sensitive metric that will, in primates, we're still working on it with humans, understanding exactly how it works. A little different for different people, but for the most part, if you have an increase in IOP, you'll get thinning of this tissue area here. So what we call this Bruch's membrane opening, which is here, to minimum rim width, to the rim, which is here. This minimum rim width area here is what you measure. And so the take home is minimum rim width will thin with an increasing IOP. And you can see what we did in the study was we took 24 different radial scans. We measured the minimum rim width from each scan and averaged them together, and you get a number that tells you what the global minimum rim width is. Now, if you look at our results, we have our test eye here. Both eyes, our control eye here on top, both eyes showed thinning in the minimum rim width. So we had one eye wearing a lens, one eye not wearing a lens. They both showed changes in the minimum rim width. We did see slightly more thinning in our test lens wearing eye, but it was not a significant change. So we can say in our normal population, we did not see significant changes in the minimum rim width or in the optic nerve head parameters as a scleral lens was being worn. So that's good. That means we're not getting an increase in IOP that's great enough to cause deformation at the optic nerve, which we know is a risk factor for then going on to develop glaucoma. And I'm simplifying this here. This is, just meant to be kind of an overview. There's a lot more to it and a lot that we don't really know about it. So this kind of busy page of graphs, basically just look at the take homes here, and you can read the paper if you're really interested in all the data. But this is showing what the actual IOP measurements were when we used the eye care and when we use the diatom. And then we actually compared the two instruments to each other. So when we measured with the diatom, we did see a significant increase in IOP immediately after removal. 2 millimeters of mercury, so statistically significant. I think in some populations, we'd certainly consider that clinically significant. In a normal population, most of us are probably okay with that, but something that we need to consider. We didn't observe any change with the diatom, but really our take home, and the reason why I sort of shrug off some of the diatom results is because the diatom has really poor repeatability and poor comparability to the eye care. So until we have figured out how to use that instrument to actually give us reliable data, unfortunately, it's not really that helpful in this. You know, if you're thinking of any patient population around the world, we can't say that gives us reliable results. So what does this actually mean for patients? And what does this mean in terms of how we see patients, right? So step one is going to be to identify patients who are at risk, right? You're going to have post-surgical patients, certainly any patients who have glaucoma. Maybe you're concerned about your patients with keratoconus. It's a collagen disease. Glaucoma is a collagen disease. We don't really know a lot about the connection between the two diseases. So identify who's at risk. I think glaucoma is absolutely the greatest risk, of course, our patients with glaucoma. Step two, establish baseline for all patients. So make sure that we have Goldman, eye care, Tonopen, whatever it is you're going to be using to measure this in your patients, get a baseline. And then I like to get a baseline OCT as well. Unfortunately, most instruments aren't going to give you this BMO, MRW metric. So I think typically we would use retinal nerve fiber layer as kind of a secondary metrics there. And then you have to check at follow-ups. And so what I do in my clinic is I'll start by evaluating the lenses in white light here. And you can see I'll also evaluate them with fluorescein and cobalt. So I'm looking here, you can see this is a lens that looks a little bit looser to me. It's not super tight. So one of the things I'm thinking when I'm putting a patient who I think is at risk, like a glaucoma patient, into a scleral lens, I want a lens that looks something like this, right? It's moving a bit. I don't feel like it's suctioning or landing too harshly on that tissue. So that's the first thing I do is get a fit that's not going to make me think I'm, suffocating or strangling that eye. And then the next thing I'll do is I'll remove the lens. I'll do the eye care. I also measure the corneal thickness with Pentacam, remembering that if my IOP is increased in my patient wearing a scleral lens, the corneal thickness, if it's increased significantly, the corneal thickness is going to probably increase as well in most patients. If I do have an increased measurement taken on eye care, and this is just the instrument I use in my practice because we can use it quickly, you don't need anesthetic, and you can take it basically right when the patient takes the lens off. If I do find that it's increased, I'll go back and do Goldman within 10 minutes. And then I will measure Goldman and see if it comes down or see if it's increasingly elevated even without the scleral lens. So just to summarize that, it's challenging to measure accurately with the current technique. So my clinical approach is take baseline and measure IOP immediately after lens removal. If I have a high-risk subject, I monitor them with the OCT, and I also integrate Goldman into my regimen there. So at this point, though, it doesn't look like we increase IOP significantly, and certainly not to an extent that would cause damage to the optic nerve head in the normal patient. But we've got to look at, of course, in all of our diseased populations. So just to summarize here, some food for thought for everyone. I think future questions, the biggest future questions for both IOP and midday fogging is what is the role of the actual lens design? Does lens design matter, or will a susceptible patient have midday fogging, and will a susceptible patient have increased IOP? I think we need to really learn that so we kind of can better establish who our patients are at risk and how we can ultimately help them. So with that, I just want to thank Contimac for having me and involving me in this really cool online class workshop presentation extravaganza, and hope everybody has a great rest of the conference.